there's an NCEP update that
precise about the calcium score. That's really something that goes beyond the role of this committee is to look at how we can alter the paradigm for identifying risk and intervening in patients before they have symptoms of disease. And if we spend too much time nitpicking CAC and we don't spend a comparable time nitpicking IME, I don't think we're in a position to do that. Every measurement we have, endothelial dysfunction is really a marker for risk. Is there an incremental risk if you release much less nitric oxide? I mean, there's so many issues here that if we could just come up with a philosophical document that lays out the guidelines for early disease detection and not get into the nuances of what number leads to what therapy, I think we might be better off. The score is to link directly to the risk of the disease, and you can read in, there's a lot of those, and that's wonderful. And if you're over 400, you are at very high risk, and somewhere between 0 and 400, your risk is moderate. And but it isn't 0, and you should be aggressively treated if that's the case. And then we've got, 3 categories. We start nitpicking into 4 and 5 categories. We're going beyond, I think, the that we have to consider other factors which are contributing to risk that need to should be we can address that on psychometric or something once the clear. We can think of it as if this gets accepted, then just a suggested scheme for treatment based upon the scores as shown in the scale. Well, I don't know. This is still just mentioning the elements and we have a picture language. So when the rules to do, we call for more attention to what should be drawn on risk management. It's easy. It's a really one 4 times a day. Now, any data about accountability based on IMP. There's no averaging higher risk, 1.2 and 1.1 millimeters. Well, it's actually age dependent. I know it's different in the right carotid and the left carotid. So it's a very complicated problem. And if we're going to go into all that, we're going to have a document which is going to be, first of all, unreadable, and second of all, we don't have sitting around the table all the IMT experts who do it. What we got is a bunch of people who make their living on CAC, and I as you're giving, they're telling us what the truth is about CAC. That's it. Describes the differences between the right and the left and the men and the women, and you're going to have to differences between men and men and the women. I think we can find, we have to refer to that. We're not 50 states. No, we're not 5. Not 2. One song was based on the American CHS. That was the debate I had 2 years ago, and I'm sure there's other stuff published more recently, but there's more. So I think you can think of one of some high points. Kind of around here, completely interesting, but that's kind of that's what I'm that's going to be different based on whatever side your mothers come up with, as far as looking at that script points out. And we have a problem to do it, and on one side is the voting, I'm going to the next one. These core subjects in 6.5 years. I'm going to make my ration for those systems underlying the values of this. I'm going to continue those. When I'm paying almost everything, I'll be almost everything halfway through. Everyone's going to be on I know all of them are going to be on ours. Everyone's going to be EBT. Everyone's going to be blood testing. For almost 2.5 to 3 months here, it's just it's the study design that we answer a lot of the questions that we can both on. One of the values of EBT plus IMG plus CRP. Two. And I don't quite right, but that's 2009. So I don't this exact data.
good. But, so if you start with 2% event rate, then anything abnormal will show you 2%. You can't really do anything about it. Well, that's into high risk, never put people into high risk categories. So severe atherosclerosis is the 10%, which is the event rate, which is a that's very well risk. So the difference between the two is that of even those mortality rate, now most cause death rather than survival. So obviously you can imagine that the curves was different. This is the same like Erica. See, it's not this problem. Corona patients, and I think Alan Taylor told me it was 1.1 millimeters, but I might be wrong. At that cut point, mostly other than that, they did achieve a 2% per year risk, and that's for high risk for future cardiac events. So things like how you want to do this, because we are strict to that therapy. Because the same approach to real life is the same as it's exactly the same story almost as the Arab study for that one. Probably those ages at a high age. Probably 50 or something. So we try to it's about that. And this is very much. There's all happens. Participate. I know, so that's down. That's that one time on risk from over 55 and the event was event-free survival. This is 900%. Sources as well, the same thing you're talking about. One thing is there, and issues 1.4, 1.06. So this is average around 60 years old, but in the next 10 years you're going to have less than 1% risk of having an event. That's pretty good. But is it comparable to your speculation? The crime is not very discriminatory within the different sectors. Irrespective of what the absolute risk was. I'm just questioning the truth. Does it not mean we don't have that kind of event? But again, that means people are but it wasn't there. They were probably put on therapy too. I'm not going to return the evidence longer than so this might be an alternative. It's not going down. We don't have to recognize. No. The business, you are. Just be 103 years long. Look at those that are sitting there, so other stuff. We'll wrap up today. Very good. I think that since can I just show them thing today, because I know it's pretty mild, but it's true. I feel sorry because it's got a lot of lives. As I mentioned last night, this is one of these things, and it's sensitive way to the rest of them.
basically the mechanism up here. So we are a function testing with the type of goes down this passage and everything.
I thought this was not just in the given. Trying to get back. So,
we've already talked about that. The emphasis here is a test result, and it's as if I'm improving a test result. And what I'd like to suggest is we do the same thing, but we stratify it based on whether or not the patient has risk factors. And I'm thinking, I'm trying to convince the patient to have this test. And the patient's going to say, well, is there only going to do this? Well, let's see. The real patient without risk factors. So if it's negative, who's going to be less than 5 years? If it's positive, we're going to emphasize this is possibly less than 2 to 4 years. If they have risk factors, and it's negative, well, we're doing risk factor modification, but if it's positive, we're going to do aggressive risk factor modification and aggressive with the roller. You can see how I have a question on that.